Hello, everyone. Welcome to this virtual tumor board. It's a pleasure to bring together international faculty to discuss these cases. Before we get started, we'll just do a round of introductions. I'm Dr. Benjamin Levy, and I'm Associate Professor at Johns Hopkins School of Medicine, a thoracic medical oncologist. I am joined here today by, again, a fabulous international group of physician scientists. We'll start with Dr. Sanjeev Bala. You want to introduce yourself, Dr. Bala?
Yes, hello everyone. My name is Sanjeev Bala, and I run the Cardiothoracic Radiology Division here at the Mallinckrodt Institute of Radiology at WashU in St. Louis. Nice to be here.
My name is Wally Kern. I'm the Executive Director of Winship Cancer Institute here at Emory University and chair of the Department of Radiation Oncology.
Hi, Dr. Levy. I'm glad to be here. I'm a professor of surgery and a thoracic surgeon at the Washington University in St. Louis.
So I'm Dr. Mark Sosinski. I'm a thoracic medical oncologist and the executive medical director at the Advent Health Cancer Institute in Orlando, Florida.
Great. So let's get started. This is a 70-year-old male who is a former smoker, 20-pack-year history, originally diagnosed with stage 3B lung cancer in 2017. He has a couple of different progressions, and we'll talk about that. He's PD-L1 negative. So let's go through this case. So this is a 70-year-old. He's got a history of hypertension, diabetes, COPD. He's got chronic kidney disease. He's a former smoker. He has a 20-pack-year history. He quit in 2017. He has no significant family history. Now, in terms of his lung medical history, he had stage 3B lung cancer. And his biopsy at that time did reveal a RET fusion. The PD-L1 was 0, and appropriately, the patient was given concurrent chemoradiation. So we need to remember he originally had stage 3B lung cancer. He was found to have a RET fusion positive lung cancer at that time, but he was stage 3B. He was potentially curable. He was offered concurrent chemoradiation in 2017. The patient does have, unfortunately, progression in 2018. And it's local progression, but he's not thought to be a radiation candidate. And we can talk about that, who and who is not a radiation candidate in the setting of local progression after definitive radiation. His MRI of his brain is negative, and because he's not thought to be a re-irradiation candidate, he's treated with triplet therapy with carboplatin, Alimta, and Keytruda. And then he's maintained on Alimta and Keytruda until 2019. Now, keep in mind, RET-directed therapies were not yet approved at this time. So he's treated with triplet therapy with carboplatin, Alimta, Keytruda. He's maintained on that up until 2019, when the Alimta is discontinued due to kidney dysfunction. And then he gets a total of 2 years of therapy with Keytruda, which ends on October 2020. So status post concurrent chemoradiation, local progression, not thought to be re-irradiation candidate, gets triplet therapy and completes immunotherapy in October 2020. The patient then presents with dizziness and lightheadedness. So this is now fast forward after the immunotherapy, presenting with dizziness and lightheadedness, and has an ECOG performance status still of 1. So Dr. Bala, I'll have you present these images.
Great. And so on the left, you can see that we've got the images of the lungs, which show this mass and some treatment-related changes adjacent. And by report, this has been pretty stable. So it looks like we have a treated lesion in the right side. Now, the brain MR very faintly shows these lesions, and it was performed without contrast because of the patient's renal failure. But you can see that there are all these punctate lesions that look very concerning for metastases with some surrounding vasogenic edema. And so stable right lung lesion, but new brain lesions concerning for metastases.
Okay. So a bit of a complicated case here in a long case. And so patient, again, in November 2020, his lung mass remains stable. Remember, he got concurrent chemoradiation and had good systemic control, at least below the neck, with triplet therapy and 2 years of immunotherapy. His PET scan doesn't reveal any suspicious uptake, but the MRI of the brain without contrast does reveal metastases, as Dr. Bala mentioned. remember back in 2017, the patient did have a biopsy that was RET fusion positive. So, this is again a battle between the medical oncologist and the radiation oncologist here. I'll turn it over to Dr. Sosinski first. Your thoughts on how to approach this patient who has CNS relapse, post-concurrent chemoradiation, followed by triplet therapy for 2 years of immunotherapy.
Yeah, I mean, I think it would mirror many of the considerations from the other patient. I mean, this would be a discussion between the medical oncologist and the radiation oncologist in terms of what the options are. I might argue for a 2 to 4 week exposure to a RET drug before committing. I'm assuming that there are multiple lesions that would require whole brain radiotherapy. So I might argue for that sort of approach, like I was similarly arguing in the other person, given that I have to believe that there is persistence of the driver. I guess that's a bit of blind faith, right? I mean, I would not expect this. I mean, I probably would do a plasma test at this point. However, with systemic disease that seems very well controlled in, relatively minimal disease in the brain, I would expect a false negative in this setting. So if you were lucky enough to pick up the RET fusion in the blood, that would make me feel better about RET-directed therapy. But again, it wouldn't necessarily sway me from a brief exposure with short-term follow-up of imaging to be sure that things aren't progressing in the brain.
Yeah. Dr. Curran, the MRI was mentioned, as Dr. Ball said, multiple brain mets. How many is too many for SRS? What's the cutoff in your mind between GammaKnife or SRS? I get a little confused on the modalities, but is there a cutoff, that you look at, or is it case by case?
There's probably approaches that vary from institution to institution. There's also technologies that can efficiently treat, a dozen or more lesions. So there's no one number cutoff. The data showing a real benefit to radiosurgery historically was sort of 6-ish or less, but now there are people who treat 10, 12, whatever. I don't know how many this patient has, but on one axial cut, we saw about 5. So I'm guessing this patient has quite a few. To me, what I'd like to do, this patient looks like there's far less bulky CNS disease than there was in the younger woman we talked about earlier. So the idea of a trial of RET-directed therapy followed by CNS radiation as appropriate seems more reasonable. This patient is symptomatic, but I think can be observed through that. Again, I think it's worth going back and looking at the cases in the RET trials to figure out how many of the brain metastases patients who responded were in asymptomatic brain met patients with low volume disease, as opposed to the 2 patients we've seen here who had high volume disease and were both symptomatic, because I think that would influence what Dr. Sosinski and I are talking about as somewhat tough clinical decisions.
Yeah.
Yeah, I would agree with that, Wally. I would bet from the data that I've seen from those pivotal trials that it's more the asymptomatic minimal volume disease. And again, we are kind of swimming in uncharted waters here with these sorts of things. My argument would be with a short-term follow-up. I'm not saying we would avoid whole brain radiotherapy, but perhaps delay it for some time in this patient. But certainly, as I said before, it's not without its risk. It's not without a full discussion with the patient and so on and so forth.
And the question really is when you evaluate a potentially, responding therapy. The data in the hippocampal-sparing radiation is pretty significant in reducing not just neurocognitive dysfunction, but some of the sort of somnolence and other symptoms. So I think we do have a different modality here at this point too.
Well, great discussion on a very complicated case.
Dr. Levy, sorry to interrupt, but I had a philosophical question about the discussion we just had. Now, and this is maybe something that either you or Dr. Sosinski may comment about, what is the general concordance between the primary lesion and a metastatic site for some of the emerging driver mutations that we have talked about for the last decade now? Yeah. And it's important to biopsy more than one location as one develops treatment plans for these patients?
Great question. Dr. Sosinski, do you want to take that, or?
I've been doing most of the talking. Why don't you take that, Dr. Levy?
Is that code for I have no idea?
No. I do have an idea. I want to see what your idea is.
Well, I think some of the data that was presented on this with the concordance between both synchronous and metachronous metastases is anywhere on the order of 80 to 90%. Yeah. And I think that's reigned true in my clinical experience. It's a great question because the name of the game in lung cancer these days is tumor heterogeneity. And there often is a different genetic makeup between a primary lung mass and an adrenal metastases. I have yet to see big differences in my clinic. The data, I think, is relatively old. I don't know if we have newer data on this, looking at the concordance between synchronous metachronous metastases within the same patient. But the data that I recall is anywhere from between 80 and 90% concordance. But Dr. Sosinski is much more seasoned and may be able to relay better information.
No, that's exactly my memory without having the studies in front of me, is that for the most part, it's relatively high frequency of concordance. And for instance, you can assume, since we do tend to see in these driver patients, it's, most of the responses we see are throughout all of the lesions that we know about for the most part, at least initially.
Yeah. Yeah, but it's a great question, and this question does become relevant in management of patients clinically. And do we need to get biopsies? And something looks a little different, should we interrogate it genomically? I think these are things that we think about in our patients. So great discussion on this case, a very complicated case, and one which is, sequenced multiple lines of therapy, which I now think we're doing for our patients. These patients are living longer and they're getting more treatment options.